Welcome to this video on the Medmont E300 Corneal Topographer. This session is designed to cover a broad range of topics related to using the Medmont instrument in daily practice, and specifically related to contact lens practice. My name is Randy Kojima. Let's begin with the case. Here we have an axial interpretation of this keratoconic patient. And what does the axial map tell us about this eye? Well, we could focus in on this gray area here. This is describing the powers of the pupil, or powers within the pupil, across this axis where the white line is. Now, if we were to focus in on the most curved portion, 61.5 diopters, find the flattest 35.25 diopters, there's a fairly broad distribution of power, something like 26 diopters of power distributed from this point to this point. So the axial map is describing for us that this eye has an extreme amount of asymmetry in terms of the power distributed within the pupil and what must be focused inappropriately on the retina. So axial provides an interpretation of vision. Another thing that we can do within the axial map is focus in on this range of power distributed across this eye. From the steepest we can read, 61.78 diopters, to the flattest we can read, 31.44, we see the distribution of power across this entire cornea, not just across the pupil. Research suggests to us when the power distribution or the scale range is greater than 10 diopters, that's indicative of an abnormal cornea. So one of the very quick and easy things we can do to determine if we have an irregular cornea is just look at that scale range of power distributed across the cornea on the axial map. Over 10 diopters, and that would be considered abnormal, possibly diseased. Now, the Medmont has disease detection indices, and here we see those principal options, the IS index, SAI, and SRI, all lit up in red, indicating this is abnormal. If these boxes were green, that would indicate normal. If they were yellow, it would be suspect. But the disease detection indices are saying that all three are above the threshold of abnormal. Now, to understand what each is, the first and maybe the most powerful is the IS value. What that does is it cuts the cornea in half and says I is inferior. What's the inferior average power of all these data points? Then S is the superior. What is the average of all these superior data points? And then what is the difference between the average superior and the average inferior? In this case, the IS value is telling you the inferior cornea is 8 diopters steeper on average than the superior. And the threshold of abnormal would be greater than 1.5. So clearly this eye is abnormally high. The next value, the surface asymmetry index, looks at the oblique meridians and says, is this side a mirror in power of this side? Is this meridian a mirror of this meridian? The more asymmetric the surface, the higher the SAI value becomes. An abnormal would be over 1.0, and in this case, surface asymmetry is measuring 12. So this is well past the threshold of abnormal. Now the last, the surface regularity index, looks at the distribution of power within the pupil and how irregular is that surface within the pupillary zone that the patient might be looking through. So in this case, a measure of 2.35 SRI value is above the threshold of abnormal, which is 0.8. 0.8 is considered the threshold where we would begin to say we're looking at an abnormal eye. Now, the tangential map is useful to understand the shape of the eye. So if we want to know how big is this cone, what is the position of the cone, the size of the cone, this is the benefit of the tangential map. It's very sensitive to where the cornea makes any radical change in curvature. So it's sensitive to soft lens or rigid lens molding of the cornea. If there's any abnormality on the surface, the tangential map is very sensitive and usually can pick it up. Now, the elevation map is useful because it tells us where the eye is high and where the eye is low. The axial and the tangential map say the cornea has power and how much power and what shape it is, but the elevation map actually tells you where the cornea is elevated in microns and where it's depressed in microns. In this case, the red saying at this point it's plus 419 microns above the spherical reference sphere. Down here, it's minus 298 below the reference sphere. So what the elevation map does is it drops kind of like a contact lens on the surface. It aligns it at 0 in the middle, as you see here. Wherever the cornea falls below that reference sphere, then you see blue. That's negative elevation. Where you see the tissue above that reference sphere, the red, that's where the elevation of the eye is high. So the elevation map is really useful related to rigid contact lens fitting because it tells you where will the lens land, that's the red, where is it going to vault, that's the blue. Now, an important value is the difference between these two, from the most plus to the most minus. The difference in elevation swing, in this case 717 microns, tells you the patient's potential for a corneal GP to work versus is it so asymmetric that a scleral lens may be called for. Now, another thing that is useful is the contact lens software. Within Medmont, you can place a rigid contact lens on eye and model the fit. In this case, we can see a rigid contact lens would be a very difficult endeavor. Notice in that deep reservoir superior of the apex, you have 156 microns. And then heading toward the cone, the lens is just clearing over top of the cone. So this would be a difficult case for a corneal GP to work. We would have so much fluid here, we're more likely to have a bubble. And if we were to go any flatter, we're going to hit the cone, hit the diseased tissue, and that would obviously put the patient at greater risk. So a corneal GP might not be the best choice for this patient. Now, we could pull up a scleral lens from within the software, in this case the ICD FlexFit, and put it on eye and model its fit. And notice the scleral lens vaults through all that irregularity in the cornea and lands way out on the conjunctiva, on the sclera, where it can land on normalized surface. So that's the benefit of a scleral lens in this case. It doesn't matter how irregular the cornea is because we're going to vault it with fluid. We're going to clear over top of the difficult cornea, land on the more symmetric, healthy, the easy surface to land on, the conjunctiva. And in this case, with such a high elevation differential, the elevation map told us 717 microns. That's an incredible amount. A scleral lens is really the better choice for this patient. Now, is it actually accurate for building a scleral lens when the Medmont E300 is really a corneal topographer? It's not a scleral topographer. Well, this study done by Young, Wright, Sobara, and Haynes showed us that a Medmont topographer used in combination with the ICD FlexFit could pretty accurately choose the right sagittal depth of initial lens, and that it could also predict the lens power within a reasonably accurate level of predictability. So the Medmont topographer, the Medmont corneal topographer, is actually quite a useful tool in scleral lens fitting because of its ability to accurately estimate the height of the anterior chamber. Now, why would you choose Medmont? You have many topographers to choose from. Why Medmont? And in my mind, there are three things that set the Medmont apart. The auto capture system makes it incredibly easy to capture an image. The corneal coverage is the largest for any Placido topographer on the market. It gives us virtually 100% of the cornea. Then the last thing is a corneal topographer is really limited by its accuracy, and the Medmont is incredibly accurate. It's considered the gold standard for contact lens application. So the auto capture system works something like this. We'll go to the capture window, select that we want to do a simple single corneal topography image. We're going to center this green crosshair to the center ring. That lines up the visual axis with the instrument axis. The red line tells you how close or far away you are from the eye. So while the red line's at the top of the runway, you're too far away from the eye. When the red line's at the bottom of the runway, you're too close. We're going to center it till we get a 95% or better, then select zoom and ensure that we have the appropriate image. So let's try that again. Let's start that over. We're going to take our joystick, center this green crosshair to the central ring, lining up those optics. Then we'll move the instrument forward until the red line lands on the green. If the red line is below or too close to the eye, we back it up till everything lands over the center. Then you'll notice the instrument just automatically captures 65%, 79, 91, 91, all the way up to 99. We're going to zoom in, make sure our central rings look good. If we're happy, then we're going to save that image. Now, the Medmont is a Placido-based topographer. And within Placido-based topographers, there are two types: small cone topographers like the Medmont and large cone topographers that have a much bigger Placido disc. Now, you would assume that a small cone topographer would give you a smaller area of corneal capture. A large cone topographer would give you a larger area of corneal capture. But really, it's the inverse is true, that the small cone topographer actually gives you the largest capture area. So a Medmont, it will generally give you no smaller than a 10 millimeter diameter. And often we can get as much as 11 millimeters even in a single topography image. So the Medmont is favored by many experts in the field because it gives you a lot of corneal coverage, a lot of data fairly far out. Now, on this particular eye, and this is my eye, relatively steep cornea, around 44 diopters or 767 millimeter flat K. You notice that it's getting at least 10.5 millimeters of information on my eye. Certainly a large enough area to calculate a large diameter contact lens like an Orthok K lens or a large diameter corneal GP. So the small cone topographer gives you a very large capture area, and that's why the Medmont's preferred by so many that deal in specialty contact lenses, because we want such a large area of capture. Now, even though the Medmont gives us this very large capture area, sometimes we get patients with fairly deep set eyes. We have small fissures. We have a lot of eyelash shadows. And here's a good example of where the capture area was fairly limited by the shadows. Now, Medmont allows us to do something called a composite capture, which has the patient fixate in different directions. In this case, fixating 4 rings to the nasal side, pushing the Placido to the temporal. Having the patient look 4 rings to the temporal side, pushing the rings to the nasal side. Then having the patient look down, pushing the rings to the superior cornea. Having the patient look up and pushing the rings to the inferior cornea. So all of these images can be merged together to create a larger view of the eye. So this is very beneficial, especially related to today's modern corneal GPs, and specifically orthokeratology lenses that are 10.6 as a starting point and usually up to 11 millimeters. So if we have only 9 or 8 millimeters of data, like many of the large cone topographers provide, we're not getting enough information to understand where the lens should be landing and on what surface shape and elevation is that. So that's where the Medmont composite comes in. Because you have this large surface area of capture, you actually are able to image a larger area than the lens you intend to fit. So the composite is absolutely critical to specialty contact lens fitting and really understanding the entire anterior surface of the cornea. Now this composite capture is very easily done, just like a simple Medmont capture. First, you'll have the patient look right down the axis of the instrument. The flower is telling you which image you want to capture, the centered image. And it says, align the patient eye to the target. Next, it's going to have the patient look 4 rings to the nose, and then we'll capture this image, 4 rings to the ear, then 4 rings up, 4 rings down, to push that Placido reflection all over the cornea. So it's kind of like doing retinal photography in a retinal mosaic, where you're trying to image various areas of the retina to string it together to create a larger view. And you're going to do the same thing with the Medmont topographer to create that large view of the eye. Now this is how the composite works. Let's go to our capture window. Let's select that we want a composite topography. Next, it's going to bring up your standard capture window. We're going to take our center image with the green and red lined up right over the center ring. We're going to get a 95% or better. We'll zoom in, make sure the rings look parallel and even. Then we'll select. Now it's saying ask the patient to look up approximately 4 rings from center. Then we'll center that green crosshair to the center ring. Make sure the red line lands on top as we move the instrument forward and back. Get a 95% or better. Then zoom in, make sure the rings look parallel and even. Then the software will say, ask the patient to look down, approximately 4 rings from center. We'll get our 95% or better. Select zoom, make sure those center rings look parallel. It's a quality image. If the rings aren't reflecting in a parallel nature, you may have topographical error. Now the software is asking the patient to look left 4 rings, and we will make sure again that the rings look good, and finally we'll have the patient look right 4 rings, get our 95% or better, select zoom, ensure the rings look like they're parallel and even, and now we have all the images we need to convert that into a composite topography. So the instrument will look for the pupil in each one of these captures to build that composite map. Once it has all of the images compiled together, it can merge them to create that one single larger view of the entire cornea. Now, you might say this is fancy topography software bells and whistles. Does it actually work? And I guess one of the best ways to test it is against orthokeratology lenses. They require a level of accuracy that many other rigid contact lenses do not. This study was a good example of how accurate the Medmont Topographer actually is. At the Hong Kong Polytechnic University, where the world-famous Pauline Cho is based, she and her PhD candidate, Kiki Tan, did this initial work to compare the Medmont topography imported into a fitting software to design the initial ortho K lens, in this case the B free lens, and they found that their first fit success was 95% with an N size of 61 subjects. So one can say that the Medmont topographer is incredibly accurate if it's able to achieve a 95% first fit success. Now, this isn't the only study. There's been numerous studies that looked at the accuracy of various corneal topographers and the Medmont, and suffice it to say that the Medmont is recognized globally as one of the most accurate instruments for understanding corneal and limbal shape. In fact, it's been regarded as the gold standard for corneal topography. Other researchers have used the Medmont to compare it against competitive instruments to determine their accuracy. If the Medmont is considered the gold standard, then how do other instruments measure up? So the Medmont is actually used against other instruments to determine if they're in the ballpark. Now, related to fitting of specialty contact lenses, this study done way back in 2011 by Christine Sindt and Trudy Grout and myself looked at diseased corneas, keratoconic and pellucid patients to determine, can the contact lens software predict the fluorescein pattern in an accurate manner to help us to accurately fit the first lens. And what we found was on diseased eyes, not on normal corneas, that it was 74% correlated. In other words, 74% of the time, the Medmont could predict the fluorescein pattern on these very diseased eyes. Now, interestingly, when you had very poor Placido reflection, when the rings were heavily distorted by scarring as an example, then it was only 12% accurate. But when you had good Placido reflection, when the rings were reflecting very well, it was accurate 95% of the time. So what this tells users is when you have a lot of distortion of the Placido, either a very dry eye patient or a lot of corneal scarring, the instrument may not predict the initial lens as accurately. Trial lenses may be the best way to begin. When you have good Placido reflection, then you can often just custom order from the contact lens software. Now, there's various types of captures. We talked about the single topography capture. Then we talked about the composite topography capture that gives us that wider view of the eye. The next is called the video capture. This actually isn't used too much today, but it was the precursor to the dry eye analysis that we're using so often today. But let's just talk about it so you have an understanding, and that'll help you to understand the tear film analysis or the dry eye analysis in Medmont. Now, what the video capture allows us to do is reflect the rings off the tear film to appreciate where we have tear film breakup or whether we have smooth and even tear film. In this case, you notice all of the rings appear slightly out of focus or distorted or broken. There are many areas where the rings just disappear completely. And that's because this patient is incredibly dry-eyed. And so the instrument can't reflect the rings off nice, smooth tear film, and so you get this poor reflection. And that can help us to understand whether we have tear film breakup and what severity that we have for dry eye. Now, the Medmont has converted that video in recent years to something called the tear film surface quality capture, to not only take that video but assess each one of the data points across that entire surface area of capture. And that's again one of the advantages of Medmont. As a small cone topographer, you get a large area of assessment of the ocular surface to appreciate how much of the cornea is in a dry eye state. So the tear film surface quality capture converts the topography not in terms of power, shape, or elevation, but in terms of the smoothness from one data point to the next. So where you see dark blue, that's where the tear film is smooth and even. Where you see hot points, that's where the tear film is not, where from point to point in that along that Placido ring, how distorted is the Placido reflection. Now, at 1 second after the blink, we see a fair amount of dark blue, less of these hot areas. However, after 10 seconds on this dry eye patient, we're seeing a lot less dark blue and a lot more hot points, indicating larger areas of the cornea involved in tear film breakup, or measuring as being dry-eyed. Now, if you look at a test over the course of a time scale, in this case 15 seconds, we see here is the blink that happens in the beginning, and that starts the test. Then the tear film moves towards stabilization. It's stable for a period of time. Then, of course, the longer we keep the eye open, the sooner it begins to break up. And we notice our surface area in breakup increasing over time. So the tear film breakup is the important measure, the auto TBUT, the auto tear breakup time. The Medmont determines non-invasively at what point you get tear film breakup. In this case, 6.2 seconds on this patient. And it's been determined that somewhere around 12 seconds is that point where we would determine a patient to be either above the threshold of dry eye or below the threshold of dry eye. So again, if you're looking at that tear film breakup time, and anything less than 12.2 seconds would be deemed a potential dry eye patient. Anybody above 12.2 seconds should be normal tear film. Now here's a 22-year-old healthy patient with a good quality tear film, and you notice after the test starts, the tear film moves towards stabilization, then it's stable for a period of time, then at 13 seconds it begins to break up, then at 14.5 seconds we have our tear breakup time measured. So this can be a useful tool in non-invasively appreciating the dry eye that may exist for a patient. And Laura Downey did this work on the Medmont Topographer and the tear film analysis back in 2015, and she found the automated TFSQ breakup time is a repeatable, non-invasive clinical marker with both high sensitivity and specificity for tear hyperosmolarity. So the Medmont can be a useful tool also in your dry eye practice, not just your contact lens practice. Now we use it at our university over contact lenses. If we put one soft lens on the right eye, a different soft lens on the left eye, then we can assess which one appears to wet better on a particular patient. In this case, at 1 second, After the blink, both contact lenses appear relatively similar, but you'll notice after 9 seconds there's a significant difference between this contact lens and this contact lens, and their dry eye scores are certainly increasing, indicating much more of the surface is in a breakup or is distorting the Placido rings. So the Medmont TFSQ assessment or dry eye test can be used in many ways. It can be used to test the threshold of dry eye, to understand the tear film breakup time, to understand the surface area in breakup. It can assess the efficacy of your treatment of dry eye from visit to visit. And you can also use it over top of contact lenses. So doing the dry eye test over top of the lens to determine how well that anterior surface is wetting and whether this is the right contact lens for the patient. Now, we've talked about a fair number of topics, but let's switch over now to soft lenses, which we haven't really spent a great deal of time on. Here's a case where we have a patient with a successful soft lens fit in terms of the lens to surface relationship, but the patient isn't achieving quality vision. And why is that? Is there a way we could use the topographer to help us to appreciate why this patient doesn't have better vision? Now, here's the RX, a -2, -50 axis 115 with 20/30 best corrected VA. So not the best possible vision from the phoropter, but pretty normal K readings, 4233 by 4284, only about a half diopter of corneal astigmatism. So nothing too interesting in the K readings, but it is curious that this patient can achieve better vision than 20/30. Now we look at the topography, and this is the axial map, and we might take a look at the powers within the pupil. Remember that axial interprets power or vision. So if we were to have a closer look at this cross section down here, the dark gray box, which highlights the powers across this white line within the pupil. So the dark gray is highlighting what's from this pupil margin to this pupil margin. And you see an asymmetric distribution of the way the powers are distributed across this cornea. Now, if we were to click our cursor on a specific point, we're 4130 on this point, we're 4364 on this point. So there's a fair amount of distribution of power within those 2 points, only 4 millimeters apart. Is this part of the reason why this patient doesn't achieve an exceptional level of acuity? That the eye just isn't ideally constructed, ideally built to bend light to the fovea? So here's a good example of how the corneal topography would indicate before we even begin contact lenses that this eye is slightly asymmetric, and that may hinder the quality of vision. So if you place a soft lens over that patient and then do topography over the soft lens, you see the draping effect of a soft lens and how it really won't correct for that asymmetry. A corneal GP may be required if better vision is desired or required for this patient. Now, along the lines of soft lenses, what about in presbyopic contact lenses? Here we have, again, a successful fit in terms of the lens to surface relationship, the centration, the movement. Everything is ideal, but we're not getting real decent quality of acuity. We over refract for distance -50, and that gives us 20/30 minus. We over refract at near +50, we're still 20/30 minus. So pushing minus or plus is neither helping us at one end of the spectrum or the other. Well, what do we do with multifocal soft lenses when the patient isn't achieving good vision? We, of course, check the fit, and we push more minus, push more plus, increase the add, decrease the add, do whatever we can with the powers of the lens to try to modify, or we just change the lens altogether. But we really don't know too much about the fit. We don't know why the lenses are successful when they are and why they're not working when we're struggling. So is there something we could do with the corneal topographer to help us to have a better understanding? Well, one of the simplest things is just to assess pupil size. And that is so easily done and automatically done by the topographer. Obviously a patient with a 2 millimeter pupil gives us very little area to push the multifocality through to the fovea. Now, if you have a 7 millimeter pupil, now you've got an incredibly large area that the contact lens is going to be bending a lot of light into the eye. Is that actually going to increase aberrations rather than provide the kind of focusing we need at near and distance? So pupil size matters, especially if we are designing a contact lens whose add kicks in at 5 millimeters. If we're placing a lens that has an add at 5 millimeters on a 3 millimeter pupil, that's going to be placed out here. The patient's never going to get the add that we need. So pupil size, of course, matters. One of the things that's very helpful as well is to understand the power distribution of your lenses. So if we're measuring the pupil size with the Medmont, it's helpful to know what diameter is the most minus of the lens. What diameter does the most plus kick in? And how far does that most plus or most minus go? So the understanding your lens designs can be really helpful in combination with your topography. Now, for this patient, we had a multi-zone soft multifocal lens on eye with a -3 power and a 250 add. What we did was we did topography over the naked eye, no lens. Then we did topography over top of our multifocal lens and did what's called a subtraction map. Subtractions are used more so in orthokeratology, but we can use them in our soft multifocal fitting to understand where the zones of the lens are. So here you can see the most minus in the center, then it looks like another ring of maybe plus, then more minus, then more plus, then more minus. So we're looking at the various zones of this multi-zone lens and where those powers are placed in relationship to the visual axis, which is right here in the center. So focus in again on the gray area where the pupil is and look at this asymmetric distribution of power. We've got the most minus there, but it's about 0.8 millimeters from the visual axis, which is right at 0.0 here. Then the most plus actually kicks in outside of the pupillary zone. So that might be indication why we're needing more minus in the center, and even still it's not giving us good quality vision, and we need more plus, and it's still not providing good quality of vision because we're not distributing the powers evenly or symmetrically from the visual axis outward. We could pull up the tangential map, and we know the tangential is very sensitive to points of curvature change, so it can really pick up where these zones of the lens are. So there's your most minus, plus, minus, plus, minus. So we see the zones very clearly, and they appear decentered, superior temporal on this right eye. Again, we could pull up that graph at the bottom and look at the distribution and see that here's the visual axis right here in the center, 0.0, and our powers do not appear centered to that visual axis. So why is this multifocal failing? Well, because the lens isn't really centered to the visual axis. And that has a lot to do with angle alpha, the temporally displaced fovea, and how our soft lenses or our rigid or our contact lenses in general tend to fit slightly temporal of the visual axis. And here that could be the reason why we're failing, that this patient has a relatively normal angle alpha, so the lens axis and the visual axis just do not line up. And maybe multifocal lenses are not going to be successful for this patient. It might not be worth trying a whole slew of different designs because we'll never line up the optics of the lens without decentered optics in our multifocals. Now, another helpful metric from the topographer is the visible iris diameter, and understanding when do we want to use smaller lenses to achieve the best possible comfort? When do we want to use larger lenses to achieve the best possible comfort and centration? So using the topographer to measure visible iris diameter is one of those very simple things you can do that is incredibly helpful in custom designing of contact lenses, and especially for those difficult cases that really fall outside of the norm. You might wonder sometimes, why am I struggling with a particular patient so much? And is it because this patient just falls outside of normal visible iris diameter? Now let's move on a little bit to rigid contact lenses. And here we have a case where the patient has spectacle blur when they remove their rigid contact lenses. And of course, spectacle blur happens when we take off our contact lenses, we put on our glasses, and we just can't see as well with the glasses on for some reason. And it's presumed that the rigid lens may be molding the eye. But here we see a rigid contact lens fit that doesn't look too bad. Is this such a poor fit that it would alter the eye shape? Well, let's look at the topography. And here is the axial map and the tangential map on the same eye. One day after removal of the lens. So we had the patient stay out of lenses for 24 hours and come in and do topography. And as you'll see, you don't really see a normal topography here. Neither the axial nor the tangential looks regular. We certainly don't see a hourglass figure eight astigmatism that is pretty typical of our astigmatic eyes and the type of patients we might fit with a rigid contact lens. We've got this island in the center, and then this thinning of the this channel through the steep curvature of the eye, this steep oval area inferior that's highlighted more obviously with the tangential map, where you see this smile down here, or this arc of steepening. So there's something very abnormal about these topographies on this eye. Now here's the patient after almost a month without wear, and now we're seeing the cornea return to a normal shape. There's your hourglass figure eight normal astigmatism in the axial map. The tangential map, obviously it's harder to see that hourglass shape, but what we do see is smooth contour from the apex to the periphery. The eye flattens at this very normal rate. So after a period of time out of lenses, we can see that that contact lens must have been molding the eye, possibly too steep for the cornea, producing that little island of steepening in the center. Being able to assess the cornea underneath that rigid contact lens or soft lens can be helpful to understand, are we molding the eye? If we have a pre-contact lens topography and a post-wear topography, we can understand how much does our contact lens alter eye shape. And then we can also use the topographer to understand when we've achieved normalization. So from this point to this point, we can clearly see there's a difference with 1 month of no lens wear. But have we truly achieved normalization? That's where you might pull up the subtractive map. So we take the patient out of lenses for a period of time. We take our topography. We see them another week, two or a month later. We can compare those two topographies to understand, is there a difference? And let's just highlight that graph area. And you'll notice that across this white line here, there is still changes happening. The cornea is half diopter steeper at this point than it was at this visit, a half diopter flatter than it was between this visit and this visit. So there's still some changes going on. This cornea may not have truly normalized following our washout period of wear. The subtractive map can be a great tool for this. If you're seeing all green and it's very close to zero all the way across, that would indicate no changes between this visit and the current visit. Now, along those GP lines, let's look at a case. Here's a patient with 2 1/4 diopters of corneal astigmatism, approximately 0.45 millimeters of corneal sill. We're looking at the axial interpretation, which helps us to understand the astigmatism, the vision. Here we clearly see a defined flat meridian, a defined steep meridian, 90 degrees perpendicular. This hemisphere of the pupil, pretty much a mirror of this hemisphere a mirror of this hemisphere. This patient probably refracts to a fairly high level of acuity. Now, let's assume that we tried soft toric lenses and we weren't able to achieve success. Is this a patient that requires corneal GP lenses, toric lenses? And with a 2 1/4 diopter toricity or centrocorneal sill, is that enough that would indicate a toric corneal GP is required? Let's switch over to the tangential map. Is there anything we can learn here? And really, it's much more challenging to see the astigmatism in the tangential map. The axial map is much easier. And you notice with the tangential, you often pick up these little areas that may affect the scale of the topography. So I prefer to look at maps axially to understand vision, and then I'll switch over to tangential if I'm thinking that there may be some contact lens molding, if it's a diseased eye and I want to understand where the cone is, how big the cone is, the position of the cone, those kind of things. We could pull up the elevation map. We see that the elevation of the eye is high here, it's low here. So it's very possible that we need a toric lens to account for the high elevation that exists across the flat meridian, the low elevation that exists across the steep meridian. Now, let's look at this cornea another way. The axial would say that we have limbus to limbus corneal sill. In other words, we see the hot meridian of the eye extending from one side of the eye to the other. That means that the depth across the flat versus the steep are very different. If you see a figure 8 astigmatism very much confined to the center, then there probably isn't a huge depth differential. But let's measure sagittal depth. The Medmont is one of the unique topographers that allows us to look at sagittal depth, height, the way we fit contact lenses. And here we measure 1060 microns. On the steep meridian, 1124 microns. So the eye has a lower depth this way than it does across the steep meridian. When we compare the two, there's a 64 micron difference between the depth of the eye this way and the depth of the eye this way. So what does that mean to you? Well, at 64 microns, that's a fair amount of difference. That means that you would have 64 microns of fluid underneath this point and this point in the contact lens, and of course landing across the low elevation of the eye. So to understand that a little better, let's pull up the contact lens software. Let's place a 9.5 millimeter rigid contact lens on this eye, and across the flat meridian, let's look for our landing at 3 o'clock here and at 9 o'clock here. So our lens is going to touch down on the surface at those opposing points, and what we want to do is steepen or flatten the base curve to create 20 microns of fluid in the center. 20 microns will allow you to just see the fluorescein under the slit lamp, to be able to say that that lens definitely clears the cornea. Now let's switch this white axis line to the vertical, to the steep meridian, to the deeper meridian. And notice the fluid layer is getting thicker and thicker as you head towards 6 o'clock, getting thicker and thicker as you head toward 12 o'clock. Now, we're always going to have the edge lift, and that's desired. But what we don't want is, throughout the optic zone of the lens, is this massive amount of greater than 40 microns of fluid that allows that lens to rock back and forth across that deeper meridian. So if we were to place that lens on eye, you see a good relationship of this fit across the flat meridian, but in the steep meridian, the vertical, we see that lens with an inadequate relationship. The lens is tilting against the superior cornea with the lid force. It's not incredibly stable. It's not incredibly well centered. We lack a decent alignment in that vertical meridian. So let's go back to the Medmont contact lens software. Let's redesign the lens with the same radius of curvature across the flat, creating the landing at 3 and 9 o'clock. Then in the steep meridian, let's use a much steeper radius across this meridian and create a more parallel or even fluid layer. Ideally, what I'd like to see is about 20 microns of fluid running all the way across the optic zone before the edge lift kicks in. Now, when we place that lens on eye, we see a good relationship both horizontally across the flat meridian, but also vertically across the steep meridian, giving us a quality centration of the lens as well as good movement and good tear exchange. So the Medmont contact lens software is a tool for us to build all of our rigid contact lens. We simply take good corneal topographies plus a composite image if we can get it, and then we'll use the contact lens software to design our initial lens. Then we just simply order the lens that the software has come up with. Now, you remember that this patient had a 64 micron difference between the sagittal depth of the flat and the steep. And our threshold at Pacific University is eyes of 30 microns or greater. When that differential in sagittal depth is 30 microns or more, we're going to use a toric of whatever sort, a peripheral toric or a back toric or bitoric lens, to create the appropriate alignment so that we don't have all that fluid underneath the steep meridian. In the case of the Orthok lens, we don't want that alignment zone way above the surface, causing decentration, maybe excessive movement, and lack of comfort. Now, is this a patient, speaking of Orthok, that requires a toric lens? Now, when you look at the axial map, you see a much more apical astigmatism. The astigmatism appears more confined to the center, not like the last patient that had truly limbus to limbus corneal cylinder. Well, let's pull up our details and we look at the K readings and we see a similar case where the corneal cylinder is around 2.25, in this case 2.33 diopters. But let's go down to the sagittal differential, and this patient has a 48 micron difference between the flat and steep meridian. Remember that 30 microns or greater, and we want to consider using a toric. So based on the sag differential that the Medmont's giving us, this is a patient that probably should be in a toric ortho K lens. Well, let's use the contact lens software. Let's build a B-free lens for this patient. And what we want to do is start with the flat meridian. And here we have our alignment with the eye surface at around 9:30 on the clock face. Then at 3:30, we have our alignment again. You notice a deep reservoir. This must be a high minus lens construction, probably a -8 lens design for this particular patient. The important thing being the lens clears the corneal apex by between 5 and 10 microns. We have our alignment out there in the periphery that traps in this reservoir that's going to create our myopic shift. Now let's go to the steep meridian. Remember that we have an eye that is 48 microns deeper across the steep meridian. And look at the alignment zone, how it's getting exponentially higher and higher. If you go back to the flat meridian, this is what we want, is that alignment or near alignment with the eye surface. And here on the steep meridian, it's just getting thicker and thicker. So that may cause the lens to decenter radically on this eye. And here's the actual fit of that lens. Not incredibly stable vertically. Laterally, it's good. We have the right depth across the flat meridian, but across the vertical, we're clearly missing the alignment. This needs to be a toric ortho K lens, or in this case, a toric B-free lens. Well, let's go back to the software, and instead of using the Symmetric, which really was a poor choice anyway, the software was telling us you'd have terrible alignment. Let's build the lens so that we have the landing across the flat meridian of the eye, landing at 3 and 9 o'clock. Then across the steep meridian, let's create a depth that will give you near alignment with the eye surface. Just a tiny fluid layer to allow for a good healthy tear pump and the appropriate lens to cornea relationship that would promote centration, comfort, and the hydraulic force that we want to achieve the myopic reduction as well as the astigmatic reduction. And then when we place that lens on eye, you notice having the appropriate depth on the flat meridian as well as the steep meridian, and we get a much better lens to cornea relationship, better centration. Now, moving along the lines of using the Medmont Topographer to fit various specialty contact lenses, let's talk about this irregular cornea, this keratoconic patient. And we might ask ourselves, is this a patient that could be fit with a corneal GP? Or in this day and age of scleral lenses, would scleral be really the best choice for this eye? Well, the story is the Axial Map will not tell us whether a corneal GP is better than a scleral for this patient. The Tangential Map will not tell you. It's the elevation map. Let's find the highest point of elevation. So we'll take our cursor all over this red and look for the most elevated point. Then we'll take our cursor over the blue, the lowest point of elevation. And that differential tells us how severe this asymmetry of the eye is. In this case, from a high of plus 164 to a low of minus 171 microns, there's a difference in elevation, a shift in height of 334 microns. Now, what does that mean to you? Well, in this study by Frank Zhang and our colleagues at Pacific University, we found that when you have less than 350 microns of elevation differential, a corneal GP can work 88% of the time. When that elevation differential is greater than 350 microns, that's where a scleral lens may be the best choice. In other words, the asymmetry of the eye is so high that a corneal GP really has a hard time managing it. So consider scleral when you're over 350 microns. Consider corneal GP when you're under 350 microns. Now, in this case, we were 334, so there was a chance that a corneal GP could work. So let's use the contact lens software. Let's find with this flat meridian, the white axis line, we'll take it around the clock until we find the point where the lens lands on two opposing sides so that we know our stability is created across that flat meridian. Then we're going to steepen or flatten the base curve to ensure that our lens clears the corneal apex, but also in the keratoconic eye, we want to be sure that it clears over the cone, over the diseased tissue. In this case, we had to steepen the base curve to create 41 microns of apical clearance before that lens would clear the keratoconic tissue in a healthy manner. Ideally, we'd like our normal corneal GPs, our corneal GPs for the regular cornea, to be around 20 microns of fluid at the center. Our keratoconic patients, we might build in a little bit more, 30 to 40, but we don't want to build in more than 40 if we can avoid it, because that's where the vision starts to drop, when there's too much fluid underneath the contact lens. Now, it may not be the fluid, it just may be the steep base curve to cornea relationship creates a drop in visual acuity, more aberrations. Now, once we find the flat meridian, we want to ensure that that lens touches itself down. By clearing the corneal apex, that gives you this landing in the mid-periphery to create the stability that we need for a healthy, rigid contact lens fit. Now, in the steep meridian, this is always where things get more interesting. When you take that axis line to the deepest meridian of the eye, we see the asymmetry that exists, that superior, there's going to be 33 microns of fluid just inside of the edge. Then the fluid layer gets even thicker, almost 80 microns. Then just over the cone, we have 20 microns. But more concerning is inferiorly, we have 181 microns of elevation above the eye surface. Bubbles are created at around 90 microns, so it may be possible that a bubble can get in there. Now, this patient had 334 microns of differential, so the elevation map was suggesting that corneal GP should work. When we use the contact lens software, we liked the horizontal relationship. We were concerned about the vertical, but since at least half of the contact lens looked good, we thought, let's give it a try. And here's the actual outcome. You see how similar the theoretical and the actual are. The only difference is the lid is pushing the lens against the superior cornea, giving you this arcuate area of landing that isn't seen as clearly on the theoretical pattern. Of course, the topographer can't model lid force and gravity, but it sure gives you an accurate estimation of the fluorescein, especially across the flat meridian of the eye. So for this patient, corneal GP worked fabulously for this particular patient. And as the study that I showed you earlier indicated, if you have good Placido reflection, the Medmont contact lens software should predict the right initial lens 95% of the time. If you have poor Placido reflection, then expect that accuracy in choosing the initial lens to go down. So good Placido reflection, we should have high confidence in that initial lens. Let's take another case. Here we have an axial interpretation on this pellucid marginal degeneration. And you notice the very flat K that's often associated with pellucid, the against the rule orientation of the K readings, high corneal astigmatism of 8.2 diopters or 1.41 millimeters, an incredibly high corneal astigmatism, and irregularly distributed within the pupil. So a patient not easily corrected with spherocylinder refraction. Let's pull up that elevation map again. Let's find the high point, plus 250. Let's find the low point, minus 200, a differential of 450 microns. So that would suggest we're going to struggle with corneal GPs on this eye because there's so much asymmetry. But for fun, let's put on a contact lens in the Medmont software. And what we find, of course, is with the against the rule orientation, a lens that wants to land at 12 and 6 o'clock. And with that extreme drop in elevation, arcuately from 9 o'clock all the way around to 3 o'clock, it appears we could be in big trouble, especially heading south. You notice the fluid layer is getting exceptionally thick, and that's going to likely cause the lens to want to just fall into this point of least resistance. Now, we look at the steep meridian, we'll take our axis line across the horizontal and look at the fluid layer getting thicker and thicker and thicker on both sides. So it's likely that we're going to have either severe nasal or temporal decentration associated also with inferior decentration. You know, the contact lens software is saying that this really isn't a very hopeful looking rigid contact lens. So there's many things that the topographer tells us. The axial map saying highly irregular, probably a soft lens isn't going to be able to provide adequate vision. The elevation map telling us corneal GP, probably not worth a try. The contact lens software is saying the corneal GP looks really horrible. Definitely a scleral lens for this case. So for this patient, we fit them with a scleral lens, in this case the ICD 16.5 millimeter lens. You notice how the lens vaults over top of all that irregularity, landing far out on the sclera or on the bulbar conjunctiva to create a appropriate landing on the eye surface that is more regular, that isn't diseased. And that creates a beautiful fit and outcome for this particular very challenging corneal shape. So the contact lens software is an incredibly valuable tool to help us to choose the right initial lens, whether it's a single vision corneal GP, a multifocal corneal GP, an orthokeratology lens. This tool is used for any of our rigid contact lens fitting to help us decide on the right first lens. But it's also a tool that tells us what not to use. It can't always tell us what is the right first contact lens. Most of the time it will, but sometimes it can't. Sometimes it does tell us, though, what not to use. And in the case of our pellucid patient, the contact lens software is saying that it would be very difficult for this corneal GP to actually work on this eye. Now, could the Medmont be used to fit scleral lenses? And we alluded to this in the beginning. Let's talk about how it can actually be used as a scleral lens fitting tool. Now, one of those things that the corneal topographer can provide is an understanding of the corneal depth. We know from research at Pacific University that the depth of the anterior chamber from 10 millimeters easily where the Medmont will take a topography reading all the way to 15 millimeters, where the vast majority of our scleral lenses land. There's an average of 2,000 microns in depth. So if we know that the average depth from 10 to 15 is 2,000 microns, if we're able to measure this depth, that might help us to better select our initial scleral lens. So let's use that average 2,000 microns with the Medmont topographer measuring the corneal sagittal depth across a 10 millimeter chord. Then we do a simple formula. With this measure, we now have the corneal sagittal depth. We add that to the average scleral sag factor of 2,000 plus the apical clearance that you would desire between the lens and the eye surface. And that tells you the initial scleral lens depth that you should select from your diagnostic set. So this can be a very helpful manner to best choose your initial depth of scleral lens using a corneal topographer. But what is helpful when you're fitting sclerals is to understand where your scleral lens is measuring its sagittal depth from. Some scleral lenses measure the depth from edge to edge and to the peak of the contact lens. Some scleral lenses, like the ICD and the ample eye lenses, measure from the point of greatest bearing, where it actually touches down on the eye surface, and what is the depth from that bearing point to the back of the contact lens. So if you know what diameter your scleral lens is using to determine its sagittal depth, then your formula will be more accurate. So in the case of a ample eye, as an example, it's a 16.5 millimeter lens that lands at 15 millimeters. Then I want to add 2,000 microns as the scleral sag factor. If I'm using a smaller diameter lens, then of course you want to alter that scleral sag factor. If you're using a larger diameter lens, you want to increase the scleral sag factor. So this formula will help you to determine the right factor for each diameter that you might be using. Now, related to irregular corneas, let's talk about how we could use the instrument to follow a patient over time. Now, here's a patient that was seen in April 2017, and we were questioning whether corneal cross-linking was really a treatment that this patient should undergo to slow down the eye growth. Now, the question is it actually changing? Has the keratoconic disease, the tissue, has it stabilized, or is it still changing? When we saw the patient next in July 2018, a little over a year later, we could look at the two topographies, and it's not completely apparent that there is a significant progression of the disease. But if we look at the disease detection indices, we see all of the numbers are going up. As we look at our April 2017 values compared to our July 2018 values, all of the principal numbers are increasing. So that is telling us that the eye is changing. It's increasing in irregularity. One of the best ways to compare two instances in time is to use the Subtractive Map. So we look at the April 2017 versus the July 2018, and then do what's called a comparison or subtraction or difference map. And what that does is it subtracts each data point, this map from this map. So it's like going A minus B equals C. What is the difference? So wherever you see hot or red, you are seeing steepening over time. Where you see blue, you're seeing flattening between these two visits. So clearly the cone is progressing. We see the area that it's popping out between those two 2 visits with the patient. This is probably a patient that should go off for cross-linking to get that eye under control and stop the cornea from getting any worse, and possibly reducing the patient's quality of vision even more and increasing their chances of needing a transplant of somewhere down the road. Now, we've talked about using the Medmont for various specialty contact lenses, rigid, soft. What about orthokeratology? This is one of those areas where it's used so importantly for treatment before ortho-K, for after ortho-K. It's really a critical tool, a necessary tool in orthokeratology treatment. Now, one of the first concepts that we want to understand is which are our patients that are ideal candidates for ortho-K, which are our patients that are going to be more challenging. When do we need a symmetric lens? When do we need a toric? And let's look at these 2 different eyes and just look at the center, especially the way K readings would interpret this patient. We would get a 3 millimeter ring to provide us with the corneal astigmatism in the center. In this case, this eye has around 1 1/4 diopters of corneal cyl. That would be 0.25 millimeters of corneal cyl. On this patient, we have about 1 1/2 diopters of corneal cyl. This patient, similar to 0.3 millimeters of corneal astigmatism for those that think in millimeters. Notice very close in central corneal astigmatism, only a 1/4 diopter separated, and a appearance that is relatively similar. With the rule, flat K is horizontal, steep is vertical. We see that hourglass astigmatism. Well, let's blow it up. Let's look at much more of the periphery. And here we see that we have very much an apical astigmatism, in this case, very much a limbus to limbus astigmatism in this case. So these eyes are similar in the center. They have similar flat Ks. Their corneal astigmatism is relatively close, but they have much different shapes to the peripheral cornea. Now, if you had to choose between these 2, which would be the easier case? Now, certainly the higher corneal astigmat is a tougher orthokeratology case, but the limbus to limbus astigmatism makes it definitely more challenging because it's harder to align the lens out here in the periphery. It's harder to push out that steeper meridian of curvature. Well, let's measure sagittal depth. How are these eyes different in the periphery? Not so much corneal astigmatism, how are they different where the lens would land? So let's measure the sagittal depth of the flat, the sagittal depth of the steep, and the difference. In this case, this apical astigmatism only has 19 microns of sagittal differential all the way around. So it's a relatively symmetric cornea in the periphery, or let's say only slightly toric in the periphery. Then our limbus to limbus case, we see 1,098 microns on the flat, 1,142 on the steep, a difference of 42 microns, a much bigger differential. So understanding the peripheral shape of the eye helps you understand when you would use a symmetric ortho-K, when you would want a toric ortho-K lens. Apical astigmatism generally performs very well in orthokeratology, and that's because we can create an appropriate alignment with the peripheral cornea, but also it's easier to sphericalize the central cornea and push out more of the astigmatism. With limbus to limbus, you're more likely to need a toric landing, and it may be trickier to push the tissue enough to eliminate any astigmatism that may be there. So one of the things that I do to understand very quickly, is this a eye that should be in a symmetric or toric is pull up my details window and simply focus in on that sag differential. How high is that difference in height between the flat and steep meridian? Medmont gives us this number as an easy lookup that's just below the K readings, just below the eccentricity of the eye, the disease detection indices, pupil width, visible iris diameter, and so on. So without having to do a great deal of analysis and clicking anywhere on the screen, I quickly know that this is an eye where I would use a symmetric. This is an eye where I'd use a toric ortho K lens. Keep in mind that 30 micron differential. When you have 30 microns or greater, think about using a toric rigid contact lens. And in this case, in orthokeratology, we're thinking a toric for the limbus to limbus patient with that 42 microns of differential. Now, what about post-treatment? We talked a little bit about how we'd use the corneal topographer pre-treatment to assess candidacy and lens selection. How do we use the Medmont after we've done ortho K treatment to understand the outcome? There's the baseline topography. There's the post-treatment topography. Here's an axial map. What would you say is the outcome of wear? Is this the ideal ortho K treatment? Is the lens riding slightly high? Is the lens riding slightly temporal? What would you say about this outcome? Well, let's pull up that subtractive map that we talked about earlier. Let's compare baseline to post-treatment and now use that difference map. So A minus B equals C for each one of the data points that the Medmont was able to measure. And what this tells us is axial relates to vision, axial relates to power. If I click my cursor right on the visual axis, the change in the radius of the cornea is 2.93 diopters, almost 3 diopters. So what does that tell us? That says that we have changed the focusing power on the fovea by 3 diopters. We've reduced the myopia 3 diopters. So I don't need to do a refraction because the axial topography is going to tell us what it is. Now, the second thing is we can look at the blue treatment zone and its position in relationship to the pupil. And it's looking fairly well centered, possibly a little bit superior, a little bit temporal on this left eye, but I'm seeing blue treatment covering 100% of the pupil. So it's actually quite well centered. Let's pull up the tangential map next. Tangential doesn't tell you anything about vision, but it tells you everything about centration. So let's look at this red ring in relationship to the black pupil. And if we highlight it here, you notice that the red ring is inside the pupil margin at 6 o'clock, 7 o'clock, just above at 1 o'clock. So certainly the lens has a little bit of superior temporal decentration. The red ring is the epithelium, where you're pulling on the epithelium and creating that steepening. That's caused by the reservoir of fluid in your ortho K lens. The blue is where the lens touches down on the eye surface. That's what creates the flattening, this blue area that we can see from the alignment zone of the lens. So sometimes the red ring isn't so clear, and we can therefore use the blue of the alignment zone to understand the centration. Now, if we were to just use the pre-ortho K map and post-ortho K map, we'd be missing an awful lot. And that's why you want to use this subtraction map in ortho K, or what's called a comparison map in Medmont. We would look at the axial to understand the power change, the treatment zone size, the treatment zone position, the tangential map to understand the lens position. So make sure that you understand how to access this map. This becomes a very important function in your analysis of the overnight effects of orthokeratology. There's so much that we can learn from the subtractive map that one single map can't tell us. The subtractive map tells us the RX change, the treatment zone position, the treatment zone size, the lens position. It gives us perspective on the quality of myopia controlling outcome that we may have created for the patient. So there's so many things that this subtractive map can do for us. Now here's the ideal outcome. This is your bullseye. This is where your blue treatment zone is centered to the black pupil margin. And we notice a 3.34 diopter myopic reduction when we click our cursor in the center. So the axial map is saying a centered treatment zone with a 3.34 diopter myopic reduction. Let's switch over to the tangential map. Let's look at this red ring here. Where is it centered in relationship with the pupil? If anything, it's slightly low, but really this is a very well-centered outcome, a good what's called bullseye. In orthokeratology, the bullseye means we got the sagittal depth of the lens correct, we got the alignment zone close or correct so that the lens centers well, we've got a treatment effect centered over the pupil and visual axis, and we've got myopic reduction. Now you may have a bullseye with an under or over correction, but it means for the most part the lens fitting is pretty close and we're getting the treatment centered where we want it, which is really the important thing. Does the lens center in the closed eye environment? Does it create the epithelial shift over the pupil centered to the visual axis? Now here's one of the adverse outcomes in orthokeratology known as the central island. And this is where you see a blue treatment zone surrounding an area of steepening inside the pupil. And there's your island surrounded by your lake. If you look at the treatment area, often in central islands, the lens is slightly low, so the treatment is slightly low. When we switch over to the tangential map, we see a red ring decentered low in relationship to the pupil, and that is because the lens is slightly tight. So a central island is caused by, or can be caused by, numerous things. It's usually an excessive sagittal depth. In other words, the lens is too far off the cornea. It's creating a suction force in the center. Sometimes it's caused exclusively by a tight alignment zone, but it's usually the combination of both. Too much apical clearance and too tight an alignment zone. Central islands can also be caused by an inappropriate lens diameter, a lens too small for a large cornea or a lens too big on a small cornea. So consider one of the reducing sagittal depth and flattening the alignment zone, but also check your lens diameter. Make sure that we didn't start out with the wrong diameter of lens. Now, the good news with the central island is that distortion, the aberrations that we create, usually disappears by around noon. So it's relatively quick, returning to a more normal quality of vision. And then we just refit. Now, here's the one that we see with great frequency. This is the smiley face outcome. And this is where we see the blue treatment zone decentered high in relationship with the pupil, giving us this smile. And this is what's called the smiley face, and it indicates a high riding orthokeratology lens with a high riding effect. The good news with smiley faces is they usually create apical flattening or apical corneal power flattening, in this case about a diopter. So smiley face patients will often tell you that they have improved quality of vision after Ortho-K, but they won't have a quality of vision from AM to PM because the treatment zone is decentered. They may lose the effect relatively quickly. When you look at the tangential map, look at your red ring, decentered high, and also in this case temporal. The red ring is well inside the pupil at 6, 7, 8 o'clock. It's at the pupil margin at 1, 2 o'clock. So our lens is decentering up and slightly temporal. A smiley face is usually an inadequate depth or a loose alignment zone. So in other words, if the lens hits the central cornea, if there's central corneal staining, you know your depth is inappropriate. You should increase the sagittal depth. If the lens is not producing staining, if it's the appropriate height, but it's too loose and sloppy in the closed-eye environment, then we need to tighten up the alignment zone. Smiley faces can usually be resolved relatively easily by either increasing the sagittal depth when it's in touch with the central cornea or tightening up the alignment zone. Sometimes it can take a few steps to get there, but normally smiley faces can be resolved. And again, the good news is patients always have reduction in their myopia, so they're often happy with the outcome, even if we're not completely pleased with the centration of the effect. Now, one of the last outcomes is the inferior displacement, the opposite of the smiley face, where you see the blue treatment zone riding low in relationship with the pupil. Again, we usually have myopic reduction. So these patients can often be happy in the AM, but that paracentral steepening can cause some aberrations, especially in more dimly lit conditions like at night. So these frowny face outcomes usually produce more aberrations. Look at your tangential map. You see the red ring low in relationship with the pupil. You also can look at the blue ring. It's around 1 millimeter from the pupil margin at 12 o'clock. It's well below the pupil at 6 o'clock. So this is your frowny face, and it usually means that you're very close to a good effect. The sagittal depth is correct, but the alignment zone may be too tight, causing the lens to ride low. Also, diameter is something to check to make sure that we don't have a big lens on a small cornea that's creating a tight fit. Generally, loosening the alignment zone is the thing to do with the frowny face. So using these subtractive maps is incredibly valuable to you in orthokeratology. It will provide for you an understanding of when you have the optimal bullseye outcome. When do you have a central island? When should you go lower in sagittal depth or looser in alignment? When do you have the smiley face and a high riding lens and need that tighter alignment zone or more depth? When do you have the low riding lens that may be too tight a peripheral alignment? Now, some of the things that Medmont does to help make things more simple or accessible and efficient is to be able to put the icons you use most at the top of your toolbar. So for instance, if you use particular icons that are under one of these pull down menus, you can right click and add them to the toolbar. So if you right click on a function that you use regularly, then you can click add to quick access toolbar. So it's right click on the one you use and then add to quick access toolbar, and it gets placed up here at the top of the screen. That way, instead of having to click on any of these pull down menus to find the function that you're using frequently, you're just clicking up here at the top, and it'll help you to be more efficient. These quick access keys are really helpful to use for the functions that you use most frequently. For instance, I use the analysis details window to get more of the the math or analysis behind various topography. I use the composite map. I use the single image. I use the subtractive map often. So these are the ones that I've added to my quick access toolbar. Now, when you're considering topography, I gave you a few reasons to consider the Medmont, and one of the final thoughts is when you're considering any purchase of instrumentation, you want to know that it's accurate, you want to know that it's efficient, you want to know that it provides you with value, but you also want to know that it's going to last. And the Medmont is really just a fancy camera with a joystick attached to it. So there's not a lot of moving parts. There's not a lot to break down on the unit. So the Medmonts tend to be extremely reliable. It's the computer that's more likely to break down on you. So if you have a problem with the mouse, a problem with the keyboard, a problem with the screen, you just go to your local supplier and purchase a new computer or get it repaired. The Medmont isn't likely to need a lot of work to it just because it doesn't have many moving parts. The Medmont makes it very easy to share information with your lab, and that's one of the reasons why the lab loves it. The labs that build your specialty contact lenses, they want an accurate topography, but they also want to be able to import that digital data into their Medmont software so they can manipulate Axial Map to Tangential Map and elevation and use the contact lens software. Then they can build the lenses that they use their proprietary designs and send them off to the lathe to be manufactured. So Medmont allows you to digitally send data fairly easy. You just highlight the maps you want to send to the lab, go up to File and Export. Then that will create this little export file that you attach to your email and send it off to your lab consultant. So rather than sending a PDF that gives no functionality, it gives you no in-depth analysis to the topography, use the export function, which sends all the digital data, the thousands and thousands of data points to your lab. Let them import it into their Medmont software, and it's like they have the topography. They took the topography themselves almost. So in closing, why choose the Medmont? Well, one of the things is certainly the composite feature that allows you to image 100% of the cornea. And since so many of your specialty contact lenses are large diameter today, we really want as much analysis as we can stretch as far out as possible. And Medmont gives us the largest analysis of any Placido-based topographer. We have all the principal analysis options: axial, tangential, elevation. There's also wavefront analysis, and we talked about the dry eye analysis. You can use the software to estimate the height of the anterior chamber quite accurately. So even for scleral lenses, your corneal topographer can be used to fit a scleral lens. And then the contact lens software is this tool that you can use to design your initial lenses for corneal GPs, for multifocals, for your keratoconic patients, your Orthok, and your scleral. Now, if you want more details on any of the items that we discussed today, go to YouTube and look up Precision Technology if you're in Canada or the US, or you can go to just simply look up Medmont Topographer. You'll come up with a whole bunch of videos. There are 26 specific to the version 6 software of the Medmont, and they go through all the various things that you might do, from calibrating the instrument to taking a basic topography. But the ones that you may find the most interesting are the building of a rigid contact lens, pre-Orthok assessment, post-Orthok assessment, there should be a short 5 to 10 minute video on virtually anything that you might do using your Medmont in clinical practice. I hope this session has been valuable to you. I thank Medmont for sponsoring me to speak on the instrument. And again, I hope there's lots in there that will help you in practice with your specialty contact lens fitting. Thank you very much.